Hi, guys, and welcome. My name is Holly Rogalski, and I am a labor doula, which means I'm a childbirth support person and childbirth educator in the Chicago area since about 2006. I also work as a medical professional educator, helping medical students and nursing students learn about history taking, patient communication, and doing particular exams that communication is very key. So I work on both sides of the patient-doctor dynamic, and I'm really passionate about helping everyone work together to ensure that each mother has the best birth that she can possibly have. I created this video series for a few reasons. Having supported about 200 couples through labor and delivery, I've noticed that my clients who haven't had some real life, no BS preparation ahead of time struggle when they get to birth. It's challenging to learn about the normal process of birth in the process of birth. It's not ideal. And a lot of parents, as they're preparing, they wonder, can you even get ready for this thing? What is birth really like? How do I feel about pain medication? Where does everybody stand during the birth? What if it doesn't go according to plan? My neighbor Sharon had her baby in the bathtub, but my coworker Bobby had a 3-day labor with lots of beeping machines. Can you even get ready for it? You can't know everything there is to know about birth, and you can't know ahead of time how yours will go, but you can learn some skills to take with you into the unknown of your birth as you get ready to become parents. So that was my motivation and my purpose in these videos, and that's what we're going to get into right now. 3 things that you got to have down before your first contraction even hits you. 3 things you got to know before labor. The first one is just a basic understanding of the process of birth, like the physiology, what is happening in your body. The second thing that you need to know, you need to be prepared for the reality of the full intensity of birth and how to cope with it. Now, that means more than just contractions, but the whole dang picture, all the parts of the intensity, and we're going to get into that. The third thing you need to know ahead of time is how to navigate the unexpected, how to be ready to work with your care provider to make choices about interventions in a safe and educated way so that you don't feel like a deer in headlights at your own birth. So let's begin with that first one by getting our bearings. Let's get a little education about the physiology and the process of birth. I'm going to label all the parts of a pregnant mother that matter when we talk about the process of birth. So here's a mother, here is a baby. The baby is contained in the uterus, which is a muscular organ that, when you're not pregnant, it's the size of about your fist, but it grows quite large to accommodate the baby. Connected to the uterus is a temporary organ called the placenta, and coming out from the placenta is the umbilical cord, which is what gives the baby all its nutrients, oxygen, and also takes away carbon dioxide. Coming out from the edges of the placenta is a membrane called the amniotic sac. It's actually 2 layers of membranes, and it's containing within it amniotic fluid. Amniotic fluid's constantly regenerating, keeping the baby, floating around in there so it's not tight. At the bottom of the uterus, the bottom portion of that organ is called the cervix. The cervix has a hole in it called an os, which is very fancy. It's Latin for hole. And then the cervix leads into the vagina, and in front of all of this is the bladder, which I'm sure you're very familiar with. Now, towards the end of pregnancy, hormones start to act on your body, and it begins to soften all these parts, soften everything. The baby drops, and the whole thing just kind of settles down deeper in the pelvis. So you can see here the basic changes that occur. Before the baby drops, the lungs are compressed, the stomach is compressed, the belly shape, the curve is kind of high, and the baby's clearly like high in the body. The cervix is long and it's closed, and it's firm. And the bladder, it's not so bad. You might feel like it's compressed, but just wait. Once the baby drops, things start to shift a little bit. Now the lungs have more room. The belly shape is low. The cervix is soft because of these hormones, and as the baby sinks into it, it gets a little shorter and sometimes even a little dilated, a little open. And then once the baby drops, the bladder is squashed even further. So there's some signs that this hormone action has happened, that this baby has dropped. Sometimes someone comments that the belly shape has changed or that baby is low. You might find it's easier to breathe and you have less heartburn. And then you begin a sexy waddle, which is not just because the baby's deep in the pelvis, but also these hormones soften the ligaments so the pelvis is unstable. Because the baby's so low, you might have to pee more frequently. There's a feeling of looseness in the pelvis, and then you might experience something called the mucus plug or bloody show coming out. Let's talk about that. Bloody what? So the mucus plug is a plug of goo that acts as a barrier in the cervix. It's just kind of keeping the baby nice and safe, keeping the baby an extra barrier to protect the fetus from any harm, any germs. So that mucus plug, it's whitish or yellowish goo. Now it loosens towards the end of pregnancy and starts to come out. And sometimes you'll see a little bit every day for even a few weeks. It does regenerate, so that's why we don't worry too much about it. You might find bits in your underwear or when you wipe, when you're on the toilet. It's totally normal. Now there's a little difference between mucus plug and true bloody show. Bloody show is mucus plug with streaks of pink, red, or brown color to it. And usually it comes out as a big glob, like 2 tablespoons. It's kind of amazing. It's a more positive sign or a more definitive sign that the cervix is starting to do some stuff. It's very normal, but it is more exciting because it is that positive sign. Now, sometimes people don't see it ahead of labor. They only see it during labor. So I'm going to show you an image of each, real images, so you kind of know what you're watching for. Real life photos. Now, if you're squeamish, go ahead and close your eyes. I will let you know when the pictures are off the screen. Here we go. On the left is mucus plug. So, like I said, whitish, yellowish goo comes out continuously. But then if it has those color streaks to it, the red, pink, or brown, that's bloody show. And we're good. So you can open your eyes if you had them closed. So while things are gearing up for labor and these hormones are acting on your body, your cervix might already start to open, but it's not until the baby gives the mother's body the signal to kick into labor. Sometimes her water will break as the first sign. There are a lot of names for this phenomenon, a lot of ways people term this. Sometimes they call it my water broke, my membranes ruptured, my bag broke, my water bag, amniotic sac, or if we're being extra, we'll call it our birth waters. And then your water can not just break, it can do a lot of other things. Sometimes it can leak, of course, break. Sometimes they say the amniotic sac ruptured. And then if we're being extra, maybe your birth waters release. It's only the first sign of labor 13% of the time. And it's not always so obvious. Sometimes it's a feeling of wetness just around the vaginal opening. Sometimes there's just a slight trickle. And then sometimes it's a true gush like what you see on TV. Now, if there's any question whether or not your water actually did break, your doctor or midwife has a few quick tests they can run in the office, but it can also change the plan of care for your birth, which is a question you can ask at a prenatal appointment. Like, if my water breaks, what are you going to have me do? Some practice say come in right away. Some will say, we'll give you a few hours and then we'll have you come in. So just asking that question ahead of time so you know what's on your radar. Now, again, only 13% of the time do people need to deal with that. So for the other 87%, the first sign of labor is usually contractions. All progress in labor is a result of contractions. That's what moves your pregnancy, moves you from pregnancy all the way through labor to having a baby in your arms. Now, the contractions are doing a few different things, and this whole process is broken down even further. In fact, there are 3 stages or parts to labor. The first stage is the opening or dilation stage. The second stage is called the pushing stage. And finally, the third stage, you're dealing with the placenta delivery, which is also called the afterbirth. So what exactly is a contraction? A contraction is a flexing of the uterus muscle. Here is a uterus. These stringy things over here in the drawing are ligaments that connect the uterus to the bones in your body. Each flex of this muscle causes the muscle fibers to shorten and pull away from the cervix. They're pulling up and away. They usually start mild and get stronger over time. Now, as that's happening, it makes the top of the uterus, which is called the fundus, thicker and thicker with each contraction. As it becomes thicker on top, it also becomes thinner on the bottom. This is where your cervix is. this is where the action is. So down here, where the action is, there are 3 big signs of progress through labor. So you can see in this picture on the left, she's early in the process, maybe nothing's happening. And then over on the right, there's a lot of changes that have happened in her cervix and in the position of the baby. The muscle action of the contractions of the uterus, they thin the cervix, so make it thinner. This is called effacement. The muscle action also pulls open the cervix. This is called dilation. And finally, the muscle action moves the baby down, which is called the station. So to help you visualize all of this, let's figure out first like where your cervix is in your body. Now, if you stand up and bend your leg, that crease created in the bend is perfectly level to where your cervix is. Now you can find the landmarks on both hip creases. And now imagine in the center of your body, in the center of where your hands are, the top of your vaginal canal, this is where your cervix lives. It's also the end of the vaginal canal, the end of the vagina, where your fingers, maybe a tampon or anything else is going to bump into. So let's talk about the cervix action right here, in the space that you're going to experience. One of the primary markers that we talked about was dilation of the cervix. Before any changes are happening in labor, that hole in the cervix, like I said, it's called the os. It's closed and firm, nothing's going on. But through the whole process of the first stage, it's going to open up 10 centimeters, all the way up to 10 centimeters through this whole thing. So from left to right, you can see how the cervix is getting open until it's completely out of the way. So here's me giving you a real life demo of the size of the cervical opening. I love this little graphic, the board thing I have. In the beginning, the holes aren't that big, right? It's 1 centimeter, 2 centimeters, all the way 5, 7, 8, 9, 10, and it's amazing how big this gets. 10 centimeters is huge for a baby or maybe your hand to go through. So that gives you a scale, a sense of exactly how big this thing is getting. But it's not just opening. It's also doing some other stuff. It is also effacing or thinning. So in addition to the numbers like 1 centimeter, 4 centimeters, they're going to throw out a percentage to you. And that percentage is just the effacement. How thin is the cervix? Most cervixes before you're in labor are about 4 centimeters thick. So walking around pregnant, not in labor, 4 centimeters thick. When the hormones begin to soften things up and the contractions start to change stuff, it gets thinner. And so they say, okay, if it's 2 centimeters thick, then we're going to call that 50% effaced. If it's 1 centimeter thick, you've done 75% of the effacement. If it's paper thin, like you can feel the baby's head through it, then we call that 100% effaced. So we've got dilation and effacement, but then in addition to that, we also have the station. Baby's going to move down. Now, if I add a line to these pictures of progress here, you can see that in each image, the baby goes south as the cervix opens and softens. So during a vaginal exam, when your provider is going to put a glove on, put 2 fingers in your vagina, they're going to be able to tell what position in your pelvis the baby has reached, what station the baby has reached. When the baby is high and floating, high in the body, it's called a -3 or a -2 station, and then it gets lower into like a -1, and then even to a 0 station. In this picture, it's a little clearer what those numbers mean. You can see if the baby's high in the pelvis, it's a -3, travels down through -2, -1, and then to a 0 station, and then starts to move into positive numbers. Now, usually baby can only descend to a 0 station until the cervix is completely dilated and out of the way. Then we're looking at the plus numbers, and that's something we really see more when you're into the second stage of labor, the pushing stage. So let's back it up a little bit. Let's go back to that first stage. Now, it's usually the longest part of labor, this dilation stage. It lasts an average of 18 hours for a first-time mom, though, my God, there is a wide spectrum of experiences here. And because it is so long, it's broken down even more into phases. So they call this early labor, active labor, and transition. Early labor is anything less than 5 centimeters dilated. Active labor is the span from 5 centimeters to 10 centimeters, And then the tail end of that we actually call transition. So it's about, 8 to 10 centimeters or like 7 to 10 centimeters. Kind of depends on what book you're reading. So that first part, the early labor, let's talk about it. So it's technically anything before 5 centimeters dilation. And that first few centimeters, that first 4 or 5 can take a long time because, in early labor, the contractions are still short, they're not so strong, and they're infrequent. They're happening kind of all over the place. And because contractions are what open and efface the cervix, there's not a lot of chances for that change to happen until it really locks into place. Now, at this part of labor, the contractions are felt low in the front of the belly. They're usually kind of vague, like it's hard to tell when they start and stop, and they're not too difficult quite yet. I mean, you might be coping, but they're not as intense as they will be. 80% of labors begin at night because that's when our hormones peak. And if most first timers can expect a labor around 24 hours in length, then a woman at this part of labor is probably dealing with like some restlessness, maybe some impatience, maybe she's trying to stay distracted, unable to lie down during her contractions, but really wanting to rest while she still can. Maybe she's wondering how long it will be and wondering how best to use her time until going to the hospital or birth center. And maybe she's like baking some cookies to keep herself distracted so that she can bring them to the nurses. And then at some point, her body will amp up the oxytocin, that hormone that causes contractions. The contractions are going to get longer, closer together, they're going to get stronger, and this will help her body progress, and eventually she'll get into active labor. Now, the technical definition of active labor is 5 centimeters open or more. Now, as things progress, the contractions begin to wrap around and are not felt just in the low belly, but also in the low back. That's a sign of progress. There's obvious beginnings and ends to the contractions, and it's requiring just a lot more focus and coping. She's really needing to pay attention and to deal with it. So what's she coping with? She's dealing with the intensity of the contractions, but also there's a shift in her brain waves, a shift in the way she's perceiving things. She will get nonverbal. Many women lose all sense of time. She begins to feel uninhibited, not really worried what she looks like. She starts to breathe deeply, and some women even moan to get through it. This part of birth requires all of her energy and focus. It is a physical, noisy, all-encompassing time. In fact, if she was baking cookies, they are probably now burning. And the very tail end of this active labor, we call it transition. This is the last couple centimeters of dilation. The contractions are at their longest, their strongest, and their most intense. Many women say that this is the most intense part of labor overall. Now, in addition to all of the intensity of active labor we just described, some women are also experiencing nausea or vomiting. She might be shaking, getting hot flashes, and then having big moments of doubt, for sure. It's called transition because it sometimes has a little piece of the next stage mixed in. Some women begin to feel some urge to like bear down just before they're completely dilated. But then when the cervix is gone and the baby descends into the pelvis far enough, she's in the second stage of labor. And before we get into that, let's just do a little review, a little pop quiz. So let's look at Sally. She's been working hard all night, relaxing through her early labor contractions. When she heads to the birth center and arrives, the nurse says she's 4, 75%, and -1. So think about those 3 numbers and let's talk about what's happening with Sally's cervix. 4, 75%, -1. She's dilated to 4 centimeters. Her effacement, the thinning, has reached 75%, almost done. And then the baby is at a -1 station, so it's pretty low. So she's doing a great job. She's pretty much in active labor at this point. She timed it really well. If we look at Brittany, she had contractions for a few days that would stop and start. We call this a sultry labor, teasing her. One evening, they became regular and more intense. And when she went into the hospital, her cervical exam was 250 -3. So what's happening with Brittany's labor? She's dilated 2 centimeters. She is 50% effaced, so half of that work is done. And the baby is at a -3 station, so still pretty high in the body, still floating high, which all of this makes sense. They usually kind of correlate like that. So she's still in early labor. They might send her back home. It sort of depends on what's going on with her coping and the other factors in her pregnancy. But this is still technically early labor. Roberta has been walking around 4 centimeters dilated for 3 weeks. Yes, that can happen. One morning, her water broke and her contractions came on very hard, very strong. She passed some bloody show, and then she felt an urgency to get to her place of birth, to the hospital. When she was admitted, the midwife's vaginal exam was a very triumphant, complete, +1. What's happening with Roberta's cervix? She is fully dilated and effaced. When they say complete, that means that all that first stage is totally done. The baby's at a +1 station, so it is now past where the cervix would be. And Roberta is past the whole first stage of labor. She is in the second stage of labor. Hooray! Let's talk about the second stage. It's the pushing, bearing down stage where the baby moves through the pelvis. During the second stage, the cervix is fully dilated and out of the way. The contractions change quality, and the average second stage is about 2 to 3 hours. Now, the contractions can space out to every 3 to 5 minutes, so maybe not quite as close and strong as they were during transition. These contractions, now their task, instead of opening, is just to move the baby down and through. Now, the mother's going to experience some changes here. She's going to feel some adrenaline as that baby descends. Her body floods her with that hormone adrenaline. And that causes an energy change in her, where now she's just more awake, more alert. She's grabbing onto things. She's thirsty. She's just a little bit more like here and present in the moment. There's also an energy shift in the room. There's more staff. There's more hands on deck. The lights might come on. There's more excitement. There's more just energy. Now, when she has a contraction, she might feel the sense of being able to work with it, or bearing down and going with an urge. So the whole game changes when she gets to second stage. Now, not only through this second stage is her pelvic floor stretching and relaxing to allow the baby to pass through it, but the baby's head is also molding into a cone shape to fit better. So this takes time and work. That's why it is 2 to 3 hours for this second stage on average. And I've seen some that were very short, and I've seen some that were even longer. Mothers are often coping with the change in sensation. So many find that the urge to bear down is a relief after that long first stage. Finally, she can do something with the pain, pushing into the urge, working with it. Some women feel overwhelmed by the bearing down urge or the pressure it's causing in her pelvis. She may experience some confusion about how to push. She might be trying to follow the directions from both her medical team and balancing that with the instincts in her body. And the hard work of pushing brings sweat, fatigue, sometimes impatience. At the very end of pushing, she may experience intense stretching of the perineum, the skin between the vagina and the rectum. And after all of that is over, finally, the baby is born. But now, there is the business of the placenta, the third stage of labor. So she's not done. Baby's out, but she's still in labor. The placenta is about 1.5 pounds, about 9 inches across. It comes out in a bundle, kind of like a liver. Compared to the baby, it's small and soft. Now, in a normal third stage, it comes out within the first 30 minutes of birth. And if it doesn't cooperate, there are medications the staff can give the mother to encourage the uterus to contract. Yes, there are still contractions. So the mother may be feeling that crampiness, though not as intense as active labor contractions. So she's coping with that, as well as the staff massaging her abdomen to encourage the placenta to come out. She's also in the midst of some hubbub as the staff work to keep mother and baby safe as they transition. So that is it. That is the process of labor in general and according to a textbook. Of course, there are exceptions. Of course, there are variations. And this is just our starting point. So the second thing you got to have down before labor begins is figuring out how to cope with it. Now, I've sprinkled into each stage, what we just talked about, some education about what a mother is coping with, but let's put it all in one place. Many people expect that the contraction pain is the hardest part of labor. I'm going to be honest with you, though. There is a whole cluster of things about the birth experience that can rock your world and surprise you. So let's talk about what all the things that encompass this intensity, all the little factors that are playing in here. First, we have, of course, the contractions. And so if you have pain medication, the contractions are taken away, but the other things are still true. So let's be honest about it. There's also exhaustion from being awake for one night, possibly 2 nights. It's hard to sleep in a hospital. Even if you get pain medication, you might need some tools to help you sleep. There's nausea and vomiting, even with pain medication or without it, for about 50% of women. The shakes, that happens as the hormones are shifting and changing, and women just kind of, it looks like they're really, really cold. They just shake through the most intense parts of labor and afterwards. Hot flashes, again, as a contraction hits, her body floods with hormones, and she might feel alternatingly like sweaty and chilled. There's the big aspect of not knowing how much longer you have, not knowing how it's going to go. And the unknown, the stress mentally, emotionally of that is a big part of what you're learning to cope with. There's also some self-consciousness, like, am I doing this right? What does my partner think? What does the nurse think? What does my doula think? So, hoping you're doing it right, hoping you're being as present and coping well as you can. There's worry about the baby, worry about how it's going for you, if there's going to be any problems. Sometimes there's excitement. That's a part of the intensity too, that you are about to meet your child. So intensity isn't always negative. There's also a mix in with that, some excitement, anticipation, anxiousness, all of it. There's some social aspects of this too. What are my friends at work going to say about how my birth went? What does this mean about me as a mother that my birth is going this way or that way? And then there's also, coping with medical interface. Like, some people really hate hospitals. Some people really struggle around doctors. They don't like the authority, or they feel really safe there. So there's a lot of dynamics to this thing that you're coping with and getting through. So how do you deal with all that? There are skills you can learn to cope with this whole gamut. The first thing is, physical positions and comfort measures for each portion of labor, like learning what kind of actual physical activities and things you can do that help you. The other one is having mental focus skills to help keep your mind calm and present and just immersed in the experience without spiraling away from you. So finally, the third important thing you got to know is how to talk about and get through any necessary medical interventions. While your body is doing the work of laboring, the medical people are also working. Doctors and midwives are doing things like, monitoring for safety and progress, keeping an eye on the big picture of the birth, and trying to head off any potential issues. The kind of interventions that might be used are medications, procedures, position changes, and movement changes in the mother, suggesting interventions if there are any stalls, like, slowdowns in the labor, if there's any safety issues for mother and baby, or even suggesting pain relief ideas. The interventions are all here for progress, safety, and pain relief. Now, you don't have to become an obstetrician. You don't have to learn all that to give birth. But you do need to know how to have conversations about interventions. You need to be able to do it without dogma, without fear, but with presence and love. Already you are making huge strides to get ready for your baby's birth. And again, those 3 things: knowing what the heck is going on in your body, learning how to cope with the intensity of birth, and then also learning to work with your provider to get outside help when it's needed. I love your comments and questions below. And if you found this video helpful, share it with your friends. The next video is coming in your inbox, and that's going to be even more helpful. We're going to get into how to cope in a more expansive way. Also, there's going to be some common mistakes that first-time parents make. I'm going to line those out for you. So watch for that, and I will see you then.